Good afternoon. Yeah, it's an honor to be as a speaker in this forum. I'm trying to talk about everyday practice. I'm a child psychiatrist originally, and I'm not so interested in weekends, but in everyday work, every day with children, but also every day when managing social and healthcare services. I've done 31 years managing of child welfare, family services, mental health services in national and also regional and local area. So you can hear my topic, so I go straight to some words why mental health services are a bit difficult to manage for managers. So 40 years ago we had 20,000 beds in mental hospitals. That was a world record per population. And then in 20 years nearly 80% of these beds were closed. So institutional care was replaced by therapeutic, pharmaceutical therapeutics and psychotherapeutic methods. And there were built offices to take care of ex-institutionalized patients. And this was a big success, but it's also a problem in our history. Because then later these offices were given preventive tasks and tasks of also treat milder mental problems. When a stigma of mental health problems diminished, so there was a growing demand of services. And new patients did not need such supervision, monitoring as did the previous patients, but unfortunately the system treated them as they would need more. So we had reforms, organizational reforms, but not reform in the treatment culture, the organizational culture. So the crisis and milder mental health problems were monitored as if they were previous hospital patients who had to be looked after. And our patient records contained quite inaccurate plans of therapeutic interventions, narratives, but to say it nastily, they reflected more the approach of the team treating and not the problem of the patient. So this is what in quite many hospitals what we have checked. The treatment idea would be number one, that we have first 3 months, 4 months, we should have weekly visit for new patients. But the actual situation is that they have first month weekly and then it declines. And then as you can see, it continues and continues. You can see even 12 years people have visits nearly as many as they have in the second month. And this should be not the case. The recommendations, once a week for 4 to 6 months. And this is what we have been trying to introduce. But as I call it, unmanaging care delivery. Psychiatry is maybe not the fastest to change it, working culture, organizational culture. So also multi-professionalism, so there are different workers having their principal ideas. So it leads to, as we had formerly, no systematic monitoring of these psychosocial interventions. So there was not connection between the clinical practice and then what the system planned to do. To say it again a bit nastily, what did we have help from ICT? We had like electronic typewriters, but not more. The missing link was how to change our patient data to information to help manage the right care. So what we need there is what is the clientele input, what is the waiting time for first visit, waiting time then to first diagnosis, what are the available various professions, resources, how to monitor the complex interplay of different professions to organize interventions that are needed. And also we have to moderate which interventions go to planet ending, what are interpreted, what are the outcomes, and what is the clientele output of the whole system. And finally, what I would like to have, as you know, in very many cases of where the patient has also relatives that need some kind of mental health services, family guidance clinics, child welfare services, child psychiatric services, adolescent psychiatric services, or then adult psychiatric services in the same family. But we have not had any system to monitor the complex helping system that our social and healthcare system is giving. So we in Central Ostrobothnia, a small district, we have never had a mental hospital, so we could build quite a modern outpatient system 30 years ago, and we were one of the leading districts in outpatient psychiatric care. But since 2000 it seems that we are getting worse compared to other districts. We had several projects and efforts to enhance our service delivery, but I would say we failed without support of ITC and using electronic records. And so this is where we got to ask Solutus, which I had learned their system in other hospitals being used, how to optimize the treatment. And now I ask Kalle to go on, please.
Okay, so thank you, Matti. First couple of words about Solutus. So we are truly passionate to reform the social and healthcare field, and let's say especially concentrating on psychosocial services. So psychosocial services, we mean mental health, substance abuse, child welfare, elderly care, for example. And to make this reform possible, we have developed the care planning system, which is called Pirkko. Pirkko connects to current and future IT systems, utilizing the data that is in there, and most importantly, complementing them with the process planning capabilities, like the interventions Matti just mentioned. So today we are about 30 employees, experts both in clinical and development work, and our service production is mainly concentrated on psychiatric services. So I guess we all know changing the healthcare is hard. And as Matti pointed out, there are some cultures and traditions which make changing mental health services probably even much harder. And I think it's fair to say that the current IT systems actually make it totally impossible to like make a real change, because they are only used for data registering and based on free text format. And with free text, you can't plan and control anything. And this is the main difference where Pirkko comes into play. So we have truly structured care plans, which makes it possible to steer the work in accordance to the latest research data, or if the research data is not there or it's too thin, then any best possible knowledge, which means like commonly agreed way of working. And recovery orientation is so-called golden standard for mental health, which is widely in use in front-runner countries like Australia. For example, it's something we have built in Pirkko. And then National Institute of Healthcare, Health and Welfare, they are very extensively bringing to child welfare now the so-called systemic operational model, Hackney model. I think quite a few must have heard about it, so that is something we are very hard working on at the moment to make that pre-modeled in Pirkko as well. So Pirkko really sees the treatment as a process, or let's say series of treatment measures. So instead of planning everything per individual appointment, we have a process which we can call intervention, and it has certain key characteristics. So content, what is actually being done, the length, how long this process should take, how intensive it should be, what are the goals that are possible to achieve with this kind of content, what are the outcome measures we want to use. There are a couple of examples about interventions which are valid for psychosocial services. Several of them can be in progress at the same time for each patient. So when talking about IT, let's say IT makes things possible, but it never changes anything by itself. So at the end of the day, only valid question is that have you achieved something with this Pirkko? And that is something I'm very happy to be here telling about. So we have been working with Soite now for about almost exactly 1 year. And there are actually some quite nice results we can show to you. So Jarkko Heino will be here tomorrow as well. Jarkko is the clinical director of psychiatric services in Soite. So if you want to talk more about this, so please check out in Brella either me or Jarkko tomorrow. So we are happy to talk about this more. So here is the first graph. So the target model Matti pointed out is that we have to have intensive beginning for the treatment. To work intensively, it means you can't work with everybody. So basically it means we have to make space in the system by cutting down the long episodes. And this is showing now what has happened for interventions in progress during the past year. So we started the project about 1 year ago. Then it took 3 to 4 months that every care plan was made structured in the system. Pirkko calculated the real starting time for the intervention, so that's why we also have the number, how many interventions were going on in 2017. Some of them had already started in 2010. So number of interventions peaked at about 1,800 the last May. And since then we had a starting point to start the hard work. So to do the clinical change, which means we have to patient by patient. We have to take into consideration, is there a reason to continue? Should we finish this episode now? Make sure you have space to take next patient into intensive care. And actually we have been able, the last half a year, last year, so together with Soite's own management, very big credit to them. They have been working really hard and been brave also to take a little bit of anger that these kind of projects always raise. So we haven't given up, and now there are about 400 interventions less going on. Okay, the next question is that have we been able to cut down the right care episodes. And this graph shows that yes, it has been so, because during the project we have been cutting or finishing the longer and longer episodes. And the longer the episode gets, the more harder it typically it is to finish. And that's why I'm very happy that the longer the project is running, the more and more also these longest care episodes are being finished. And then something extremely interesting. So in the system there's constant monitoring that we don't sub-optimize. So we don't want to, let's say, create a hassle in emergency unit by, let's say, violently cutting down the psychiatric episodes and then people are seeking help from emergency units. So here we are modeling how much other services of Soite those patients have used whose psychiatric episode was finished between May and September last year.
Including primary healthcare.
Yeah, including primary healthcare. So all the units that are in the electronic patient record, all the visits are there. And it's extremely interesting that actually patients have been using 30% less other services 2 to 3 months after the psychiatric care was finished than they used during the last 2 and 3 months while the episode was still going on. The concept in Pirkko and also in this data modeling, it's generic. So for example, that kind of modeling could immediately be implemented in elderly care. And that would be the way to answer the question, how is the service use developing, for example, after assignment to home care, which I guess would be extremely vital question for both service providers to make sure the buyer is getting value for their money. And modeling always operates at the patient level, so it means we can also flag out the clients whose service use is not developing as expected, and then take the necessary actions. The most important time in this project is right now. So it means now we know there is more space in the system. We have to make sure that space is used right, which means every new patient coming in will get more intensive treatment, which we know to be more effective. And this slide is the one I'm most proud about. So it's comparing the treatment intensity at the end of 2017 to the end of 2018. And it shows that actually beginning of treatment is about 30% more intensive now than it used to be a year ago. So there is still a huge way to go to the target of weekly visits, but I'm sure there is now enough momentum that if we just can carry this out, it's going to be very different in 1 year time. And this is something that definitely doesn't happen by chance. I don't know how many liters of coffee and how many pullas has been eaten in Finland when discussing about changing the way psychiatric patients are treated. But it has never changed anything, but now I know we have been able to do something. Matti hoped for family level integration, and I'm pretty sure I hope it even more than Matti. So the structured nature of Pirkko makes it possible to also share data on family level, and we have a predefined logic for consents which are needed. So that means we actually can create real-time family level care plans which are visible for every employee working with any of the family members and family itself. And I believe this would be functional integration and let's say like a revolution of psychosocial services, which I'm really hoping we can start to check out in in Soiteo with some other of our customers during this year. Okay, thank you.
And let me add once more, there are two big health economic issues here. The other one is, as you know from health economics, that there are certain households, certain families that have big psychosocial problems. They use quite a lot of the whole service system. So if you can monitor the help of these, not from unit by unit or clinic by clinic, but the whole family system, you can change quite a lot. And also, if you put the slide before, another big health economic issue is that mental health problems are a big issue on the national level. And it's not the treating costs, but 2/3 of mental health problems costs to society is from losing capacity of work. Now, this change means that the people get quicker, decent help, good help, and return to work. So these two things make it that this is also a health economical issue.
Okay, thank you.